Joining me in conversation about the current COVID-19 pandemic are Stephen Riley, Professor of Infectious Disease Dynamics, an epidemiologist who uses mathematical models to answer research questions that are relevant to public health. Also joining me is Cooke, Professor of Infectious Disease, who is a clinician focusing on new treatments and diagnostic methods for COVID-19. Welcome and thank you for joining me.
Thank you for having us.
Good to see you.
Considering your respective fields of epidemiology and the clinical field, where are we at in the COVID-19 pandemic now?
So we've learned an awful lot more about the transmission of this new virus, and different regions and different countries around the world have reached different points in their epidemics. I think it is a good point to stop and take stock a little bit. Obviously, we're based in the UK, and we have had a very effective lockdown, and case levels are down to very relatively low levels, not as low as some other countries around the world, but much lower than they were at the peak. And we're looking forward now with a little bit of apprehension about what will happen next, what will happen to cases now that the lockdown has been relaxed and we are gradually returning to a more normal life. Elsewhere in the world, the patterns are very different from New Zealand, where they have essentially achieved a kind of ongoing elimination, it seems, to the Americas, where they're having very large ongoing waves of infection across the southern USA and in South America. So I think we're at lots of different points.
And in a very short space of time, we've learned an enormous amount about the virus and about how it replicates, how it transmits. So we understand much better, for example, that people can transmit the virus when they're asymptomatic or before they're symptomatic. And we've started to see new treatments becoming available that target the virus and the body's response to it. And at a local level, we've been through the period, as Stephen describes, of extremely heavy burden on the NHS and on services through March and April, which has gradually waned over the last couple of months. But we're now in a position where we've got, at a local level, relatively little transmission, but there are occasional hotspots which flare up, and they're obviously a focus going forward, trying to prevent the infection receding and coming back at scale.
So both of you are involved in a study called the Real-Time Assessment of Community Transmission Study, or REACT study. Can you explain a little bit more about this study and the first findings that were recently presented?
Yeah, so as I mentioned before, we were able to follow cases in the UK, and people going because they've got symptoms, going to the doctor or asking for a test. That gives us some valuable data, but those data are confounded a little bit because they depend on how people behave, how they feel about testing capacity. So in the REACT study, what we're trying to do is have a kind of almost entirely independent source of information about what's really going on in England. And what we do is, rather than kind of waiting for people to become ill and seek a test or seek treatment, we are kind of proactively, we're selecting a representative random sample as best that we can, and then we're asking individuals to take a biological specimen, take a swab or use a blood sample, so that we can build a picture of what's going on that's kind of independent of the other testing processes. So that's the underlying motivation. It's kind of split into two. I'm more involved in REACT 1, which is looking for the virus. So we're asking people to swab themselves and then send those swabs back to us. And I'll maybe hand over now to Graham, who's a bit more involved in REACT 2.
Yeah, so I think, as Stephen says, there's two major components to the REACT study, REACT 1 and REACT 2, and they're both important to take together, but they're quite different in what they're doing. So REACT 1, as Stephen described, is using tests, these PCR tests that we use that amplify very small amounts of virus to detect it in people, and people are swabbing themselves and sending swabs in to be assessed. And that gives us a very clear snapshot of how much virus is in the community at any given moment, and then we can ask about where it is and who's got it. REACT 2 is focused on antibody responses. So it's using a very different type of test. It's using a test to look at those antibody responses that individuals develop after they get the infection, that may take some days to develop and then last hopefully for months, and we don't really know how long they last for. But we can use these tests, these lateral flow tests or finger prick tests, to try and get a snapshot again of how many people have got antibodies and use that as an estimate of where the virus has spread through the community. So the PCR testing and testing for the virus tells us immediately now where the virus is, and the antibody tests give us a sort of a cumulative view as to where the virus has been over the last few months. And so bringing those bits of data together can give us insights into transmission of the virus and obviously more importantly what we do about it going forward and where we have to target our resources.
Recently you published initial results from both these studies. Can you give some insight in what these very first findings were?
I'll let Stephen start with React 1 and then
so we've completed one round of React 1 where we got results from swabs from just over 120,000 people. And I'd probably highlight three interesting findings that came from that. The first is that even at the end of lockdown, this study was done towards the end of May, the majority of the samples, we found that the prevalence was falling still quite rapidly. So the R number that was associated with it was just over 0.5, and that's a little bit lower than R numbers that have been estimated from other data sources. So that was kind of reassuring. That means the way that we all changed our behavior during lockdown, the way that we've eliminated risky contacts and stayed home, was even a little bit more successful in the community than we thought. We also found perhaps a little bit of a higher proportion of people were asymptomatic when we tested them. So 70% of people at the time they gave of the people that gave a positive test, about 70% of them hadn't had symptoms in the week prior to that. That doesn't tell us exactly what one person's chances of developing symptoms. That's a bit more complicated. But as a picture of the epidemic at a point in time, that's telling us a lot of the people who do have the virus are not aware of it, perhaps a few more than we might have thought. And I think the final finding I'd highlight is that even at the end of May, the care home workers and healthcare workers were there were many more positives among those groups than you'd expect by chance. So although infection control was undoubtedly improving all the time and was at very good levels, the epidemic was to some extent at that time still probably being driven from those settings.
So these tests can actually tell us something about the number of infected people in the community over time.
Yeah, that's right. So we, because we're taking a very high number of tests and they're spread out over a couple of weeks or even a little bit longer than that, we can look at the trend per day that the swabs are taken, and we do have some power to detect trends in that, and we did observe a pretty strong downward trend even in just a kind of 2-week period during the end of May.
Yeah, and a couple of other things I think that it's worth highlighting from the first wave, if you like, of React 1 is one of them is the suggestion of differences in the prevalence of virus in different ethnic groups, and we're seeing suggestions that we've got higher prevalence of virus detected in Black, Asian, minority populations, which needs to be explored further in subsequent waves. And as Stephen says, we'll get more value from the next wave where we can then compare to what's gone on, and there's a plan to repeat these waves of assessment to try and establish better where transmission is. And the other thing that we can start to get is some sense of where in the country the high prevalence areas are. So, we see evidence that London perhaps has a higher prevalence when we looked in May, and areas like the southwest have a lower prevalence generally, although we don't have that much power despite the sort of high numbers that Stephen's described. And this is really a very big study. I don't think anything's been done on this scale that I'm aware of in any other country at this point. I imagine others will follow. But even with that scale of testing, you can't get down to a very low level to identify hotspots, if you like. And obviously the ambition would be to be able to find places like East Leicester that you could then identify as places needing more intervention. And hopefully with more waves and a bigger scale of testing, that might be possible.
I see. And then there is the React Study 2 that also has had some preliminary results.
Yeah, so React 2, the ambition, as I said earlier, was to look at antibody testing across the country. So we've just completed that first wave, but we don't really have the data to share just yet. We're in the process of analysing that, and hopefully that will be out in the next week or so. But I mean, what we had to do as part of that was a number of studies to try and understand how to use these tests. So unlike the PCR tests, the antibody tests haven't been so well validated, and they hadn't been used at home. And there was quite a lot of mixed publicity about how good they were, and that was quite high profile. So we felt before we could go out to large numbers of people in the population, and we've sent these to over 100,000 people too, that we had to do some work with the tests to give us confidence and to give other people confidence to use them. So we've done a couple of studies with colleagues, in particular Professor Ward, who's based at Imperial, but Professor Barclay and Professor Darcy and Professor Elliott and a few others. There's been a big team involved. One part of that has involved looking at patients. We recruited staff from NHS trusts who we knew had the virus, and then ran the tests with them in clinic to see how well they performed, and also ran those tests in the lab to see how well they performed in the lab, to give us a sense of confidence about their performance, but also to allow us to adjust the estimates later on if we need to, based on how sensitive they are and how specific they are. So for those who are not so familiar, if we're talking about sensitivity, then we want to know, for people who've definitely had an infection, what proportion will be detected by the test, and that's a measure of sensitivity. And we'd like that to be as high as possible. And a number of the tests we evaluated have sensitivities over 80%, which allows us some confidence to use those. So alongside that, we did a large piece of work with public panels and users to try and understand the barriers to using these tests, some of the challenges, and then that allowed us to optimize the packaging and the instructions that we then emailed out. So that was a huge study just to do that. So that was over 12,000 patients who did that a couple of months ago. And we put that all together to then build what we then mailed out to people with instructions that we thought they'd be able to use safely at home and provide the results. And they then uploaded those results themselves. And one of the key issues is that we have other tests that are based on the laboratory that we can use for antibody testing, but you have to take a blood sample and process it in a central lab, and to do that for 100,000 people, or to do that at scale, is a really big undertaking. And by using these lateral flow tests, we can actually do things more nimbly, even though the performance of them in some cases may not be quite as good. Actually, in many cases it is as good. We can get a lot more information a lot more quickly, which is obviously more important for policymakers when they start to think about what the decisions are they need to make.
Amazing. Going forward, the Academy of Medical Sciences has recently presented a report on preparing for a challenging winter. Would you be able to explain what the worst case scenario that is described in that report is and what we can do to prevent it?
Yeah, I think these reasonable worst case scenarios are something that most people hadn't heard of until 2020, and are now a little bit of a topic in open discourse. And they're really driven by various departments in government need scenarios against which to plan, and that goes down even to local government. They need to provide, so many masks, so many gloves, all these different things. So, and they have to have a scenario against which to plan. So that's what a realistic worst case scenario is. And I was part of the large group that worked with the Academy of Medical Sciences for that report. And the first thing is, it's important to know that it doesn't assume any specific government policy. It doesn't prejudge or anticipate. It's just, at the request of SAGE, it was to come up with some epidemiological scenarios that we thought were definitely plausible and possibly, for whatever reason, may not, generate strong interventions. It wasn't saying that government wouldn't do it, but it was plausible that in some circumstances they may not. So it's a subjective set of kind of parameters, if you like, that produce a pretty bad epidemic of COVID in the UK over the following winter. And in terms of making sure that doesn't happen, then there's a whole suite of interventions that the government is considering, and we would expect a combination of local interventions, hopefully, to be sufficient. And then obviously there's a lot of debate about whether there would be any need for a national intervention if circumstances were to dictate that. But obviously that's way beyond the remit of teams trying to generate these scenarios.
But just in terms of the broader context, then, I mean, it's important to recognise that one of the drivers for the policy changes and the policies that have been implemented, particularly during this first wave, has been the pressure on the NHS. And so going into winter, every year there's always pressure on the NHS, and that's really driven by respiratory viruses as a whole, and viruses that we've come to live with and come quite familiar with, flu being the most obvious one, but other ones too, like RSV and parainfluenza and many others. So one of the concerns in autumn going through to winter is that a resurgence of SARS-CoV-2 in that context would have a bigger impact on the NHS as a whole, which is going to be an important issue, and also trying to establish who's transmitting this new virus in the context of other viruses becomes more difficult. And in some ways, we've had it quite easy up to now in that respect, because the early first wave of virus coincided with a decline in the seasonal viruses, and so there really weren't very many other viruses circulating. Although we have to hope, and I don't know if Stephen can comment, but we have to hope that some of the measures that have gone in place may also have an impact on these other viruses, and it'll be interesting to see how that impacts through the winter.
Yeah, and that, I think, we're doing all this work to improve preparedness and to help make the best decisions and that we possibly can. But there is some fascinating underlying science going on here as well, and we have to prepare for the worst, that flu may be additive to COVID. That's what we're preparing for, and we have to anticipate that. But given that COVID looks to be a bit more transmissible than flu, and that we've managed to become more COVID secure and reduce transmission of COVID quite a lot, there's a theoretical argument that flu might struggle to transmit in a population that's attempting to be so COVID secure. As a caveat upon caveat, we can't in any sense predict that will happen, but we'll be watching very, very closely, because if something like that were to happen, that then changes our immune profile against these other viruses, which then actually becomes something much more policy relevant that we would track. So there's some really interesting potential dynamics in the trade-off between these viruses.
And we've seen that reflected in some of the advice coming out this week, actually, about trying to increase the uptake of flu vaccine. So I think that's part of the package of what we need to be doing, is also to think about these other viruses that may be circulating. And Stephen says hopefully less than normal, but I think if we can reduce that further with vaccination and high levels of vaccination, that will be very beneficial.
So you've both touched on this briefly already. What are, in your view, the most important topics to focus on for research going forward?
Well, there are many. I'll start, but I think above and beyond everything is the need for a vaccine, because I think an effective and safe vaccine transforms what you can do from a public health perspective. And clearly, this has been recognised now for a few months, and there's been really substantial investment globally, but also nationally, in different vaccine efforts. And those are moving with incredible pace. When you think that we had never met this virus last Christmas, and now we have a number of vaccines that are already into phase 3 trials, which vary in their likelihood of being successful, but nonetheless, we would be hopeful by the end of the year we're starting to see vaccines that can protect. That would be fantastic. And clearly, if you can protect a large number of people effectively and safely, then transmission is much harder. Economies can unlock and everything transforms, but we're not there yet. And so in the meantime, we have to focus on other things and many of the more public health relevant areas of research. Stephen, do you want to?
Yeah, no, I'd agree with those. I think from kind of the dynamic side, I'd emphasize understanding local patterns and the locality of it. There is a lot of little bits of virus all over the country, but there's obviously hotspots that we're reading about in the news, and we need to really understand how they arise, how they are being dealt with, whether the local lockdowns are really working or not, and then how that's going to progress is if there's a tiny kind of background increase that goes along with that. So there's some key stuff there. I think on the vaccine side, there's also going to be some really interesting dynamics as well. That what we really want is a very, very safe vaccine, and we want it to be good as well, but we want something that's very, very safe, so we have the option of using it in large quantities over short periods of time. Because even if it's not perfect, even if it doesn't give everyone perfect protection, we're doing a really good job with our changes of behavior now. And if we have something very safe that we can rapidly give to large groups of people, we can make a massive difference to the amount of infection that's out there without necessarily having the most effective vaccine. So I think, given the number of candidates that are out there, those types of trade-off between safety and our knowledge of safety and duration of those safety trials versus the potential benefits of some large-scale use of imperfect vaccines is going to be a really important question going forward.
And sort of related to vaccines, but separately, I mean, one of the key big scientific questions we need to have answers to, and they're starting to emerge, is what it means to have an antibody from infection, and to what extent does the fact you have an antibody, an IgG antibody in particular, protect you from reinfection, and probably more importantly, how long does that last? And so, inevitably you can't answer that question until you've had more time, because you've got to follow people over time to see how things fade, and we're starting to see data coming through from the first countries affected, in particular China and so forth. So when we understand that better, and obviously the hope is you have quite prolonged protection for a period of time, but we don't know that, and other coronaviruses, we have evidence that fades over time. And how that pans out has a big effect on what we can do from a public health response. But I would also echo what Stephen's saying about knowing the local epidemic, and this is true for many other diseases. And I think in HIV we've always had the mantra for many years of know your epidemic, know your response, and that really applies very much at the local level. And from a public health perspective, joining up the sort of data that we're getting from studies like REACT, but others too that are going on, with the local public health response is critical, and that's been something that's not been done as well as perhaps we would like up to now, but that will be really important if we're trying to get an early grip on outbreaks as they occur in local settings.
Thank you both so much for sharing your insights with us today.
No, thank you.
You're welcome.